Hello real clinicians. In previous quick tip videos, I talked about when we should remove a crown versus filling the access preparation following root canal therapy, and when we should do a bunch of different things related to crowns. And an important restorative question came up by one of our viewers about when should we even do a root canal prior to placing a crown, and I thought that was a great question and should be the topic of this Friday's question. Now, we've all heard advice regarding when to do the root canal prior to the crown. Some people talk about the remaining thickness of dentin, some people advocate doing it in all cases, and others recommend not to do it at all unless the tooth is necrotic. As usual, the answer is somewhere in the middle and requires some consideration. Before we talk about anything, let me just tell you that studies show that about a quarter, 10 to 20% of teeth that even have normal pulps that get crowns end up requiring root canal therapy down the line, and that rate goes higher the larger the restoration prior to the placement of the crown. Now, this number is higher with bridges, and it's probably due to some of the rocking phenomenon that can happen with bridges. Now, whether this pulpal change in time is due to the individual patient's oral hygiene or the quality of the crown or the bridge that is made, whether it's hermetically sealing the underlying dentin from bacterial contamination. Now, that has not been really studied in much detail, but keep in mind that this number goes higher with time and with the deterioration of the restoration and its margins. The most important predictor of symptoms following crown preparation and cementation is the preoperative pulpal and apical diagnosis. The next most important factor is the operator technique for crown preparation and luting or bonding cementation, because obviously you should not damage the pulp during the preparation, and afterwards you have to have restorative margins that certainly are not open that allow bacterial seepage, nor do they trap plaque that could be a source of future decay and leakage. It's all about micro leakage, folks. So here, let's talk about the diagnostic factors in this video, and we can address some of the other factors that I just mentioned in future videos. I promise you I will do that. A pre-operative diagnosis is always required for both the pulp as well as the apex before a burr is even placed on a tooth. Keep that in mind. It's for all restorative, even fillings. You need to always have a pulpal and apical diagnosis before you do any filling. You need to do the historical, radiographic, and clinical tests to determine the status of the pulp before beginning the crown preparation or any restoration for that matter. And if the pulpal diagnosis is irreversible pulpitis or necrosis, you obviously have to do the root canal prior to the crown preparation or immediately thereafter. However, when the diagnosis is a normal pulp or a reversibly inflamed pulp, the decision obviously is a little bit more tricky and somewhat more challenging. Here, what you have to do is you have to make a call based on the strategic value of the tooth and the risks of potential necrosis. Now, remember that endodontic success rate is much higher in vital teeth, and therefore Prophy Endo, in questionable cases, can ensure a better endodontic outcome than waiting until symptoms appear or after the tooth becomes necrotic. So, on the other hand, though, some patients are financially strapped, and you need to have a practical approach in these cases, such as placing a core or a provisional crown, a well-sealing provisional crown, may I say that, with proper occlusion, and then monitor the tooth for about 8 weeks prior to retesting the pulp, and then placing a definitive crown if the pulp remains vital and there are no symptoms. So just retest it again with your cold test. Keep in mind that the goal is to optimize the outcome based on the patient's priorities as well as their limitations. Understanding pulpal anatomy is also a key concept. Avoiding prophy endo in teeth that have complicated root anatomy may be sometimes warranted because if there is a very challenging root canal therapy that is expected, you need to always, when facing these anatomies, in cases that are questionable, not cases that are obviously irreversibly inflamed or necrotic, you always have to balance the risk of no treatment versus the risk of treatment, which is oftentimes not considered. Therefore, pre-pros endo is not a panacea, and it requires a nuanced approach by an experienced operator who can communicate risk versus rewards clearly with their patients. That's an important point. Beyond the preoperative diagnosis, other factors that should obviously be considered for the risk of necrosis are operator technique. Now, how to maintain pulp vitality is a very long discussion and will certainly be the subject of future videos. I will make those. Here, I just wanted to emphasize two important points for making a decision about doing the endo prophylactically or not. And the first factor is an accurate preoperative pulpal and apical diagnosis, which can only be done with thorough clinical examination and not by the x-ray alone. The other factor is a decision based on the strategic value of the tooth and whether it will be an abutment or not, and the root morphology and the degree of difficulty involved here. So, when in doubt, as long as the patient is an active part of the decision making and you have proper consent, do the endo. Now, in future videos, I will discuss ways to avoid pulpal damage as well as necrosis, and then during the restorative procedure, how you can keep these teeth vital and do your restorations as atraumatically as possible. So don't forget to share these videos and also leave your comments below. I always love to hear from you and your views and how you agree or disagree with whatever I say. From Boston, Massachusetts, and for Real Endo, I'm Ali Nasseh, and let's save some teeth.